The most important abstract was the one of the OPTIMA trial. The OPTIMA trial is going to answer a very important question, which is the impact, the benefit of chemotherapy for patients with more than 3 nodes, and of course, with the nodal involvement that is more than the one that has been used in the responder. I will provide an overview of anything that has been presented during ASCO on HR-positive breast cancer. Of course, I did a selection based on what I believe is interesting and important, but to be honest, last night I shared with Professor Hope Rugo which are potentially the most impacting abstract presented at ASCO on HR-positive HER2-negative disease. And personally, we both agreed that maybe the most important abstract was the one of the OPTIMA trial. The OPTIMA trial is going to answer a very important question, which is the impact, the benefit of chemotherapy for patients with more than 3 nodes, and of course, with the nodal involvement that is more than the one that has been used in the responder. This was a prospective randomized trial with a control arm in which patients received chemotherapy plus endocrine therapy, and then a test-directed arm. All the patients with a recurrence score more than 60 have been randomized exactly to receive a chemotherapy plus endocrine therapy versus chemotherapy alone, and the patients were blinded to randomization. All patients with a recurrence score less than 60 received endocrine therapy alone. The primary outcome was invasive breast cancer-free survival endpoint, including local, regional, and distant relapse. And the primary analysis was done by pre-protocol population with a minimum follow-up of 1 year. The non-inferiority hypothesis was a 3% absolute non-inferiority margin for invasive breast cancer-free survival. Of course, this is completely arbitrary. In margin equivalent studies, of course, every time we discuss the absolute non-inferiority margin, this can be arbitrary because, of course, maybe in the adjuvant setting, also a benefit of 2% can be accepted by the patients. 4,420 patients have been randomized, half of them to control arm, the other one to test-directed arm, just to study the distribution of recurrence score. You can see over here that 67.8% of the patients had a recurrence score of less or equal to 60. Who are the patients included in the OPTIMA trial? 38% of them are premenopausal, 61% of them are postmenopausal. We have also 80 men here. The majority of the patients had a tumor of less than 3 centimeters. Grade 3 was observed in 31% of the patients, grade 1 and 2 in 69. Regarding the specific question of the trial, 1 to 3 nodes were present in 74% of the patients, and 4 to 9, that is the most important question, only 18% of the patients. When evaluating events in the context of the OPTIMA trial, any invasive cancer event was observed in 7.2% of the control arm and 7.8% of the test-directed arm. The majority of the events were locoregional or contralateral breast cancer. But of course, invasive breast cancer-free survival event altogether, when 7.2% in control arm and 7.3% in the test-directed arm. Just to look at the distribution of this event, you can see over here that the trial demonstrated the non-inferiority limit in the intent to treat population that was equal to 2%. So there is no certainly benefit from chemotherapy. This is the intent to treat population, not specifically the cluster of 4 to 9 lymph node. When evaluating the distant recurrence-free survival, again, there is a non-inferiority between chemotherapy plus endocrine therapy versus endocrine therapy alone, with an adjusted hazard ratio of 1.04 and 1.17. When assessing this benefit across menopausal status, there is absolutely no difference between premenopausal and postmenopausal women, with 1.3% observed 5-year difference that may favor potentially chemotherapy. When assessing the nodal status, invasive breast cancer-free survival versus nodal status in the low recurrence score, there is absolutely no difference when evaluating 1 to 3 nodes or 4 to 9 nodes. So in conclusion, optimized that Prosigna test identifies a patient group with minimal, if any, chemotherapy benefit. At most, 2 recurrences will be prevented for every 100 patients. This is, in my opinion, an extreme extrapolation. The 50-gene test can assist safe adjuvant chemotherapy decision for premenopausal women and for patients with 4 to non-involved lymph node or stage 3A tumors. This is the conclusion, of course, of the authors. I don't believe if really the OPTIMA trial provided an answer to this question. I am still not confident potentially to omit chemotherapy in patients with 4 to non-lymph node involved, since only 18% of the patients have been included in this trial. I really believe we still need another trial. Potentially, an academic trial is ongoing, also incorporating the use of CDK4/6 inhibitors in this setting. Then I will rapidly do an overview of other trials and other updates. One was on the NATALEE trial. The NATALEE trial was a prospective randomized trial comparing ribociclib plus endocrine therapy versus endocrine therapy alone in patients with intermediate high-risk early breast cancer. Ribociclib was given for 3 years at the dose of 400 milligrams. The primary endpoint was invasive disease-free survival. With a longer follow-up, of course, we can confirm that ribociclib had a benefit in terms of reduction of the risk of invasive disease-free survival. In this analysis was performed the PAM50 analysis across stage. And in the NATALEE, finally, the number of patients that have been studied with PAM50 identified different subtypes, luminal A, luminal B, HER2 enriched, and basal-like. Surprisingly, seems that ribociclib can provide a benefit not only in the luminal A and luminal B, but also in HER2 enriched and in basal-like PAM50 subtype. Of course, the main conclusion is that these analyses show that ribociclib benefit in NATALEE extend across intrinsic subtype and highlight the gene expression characteristics with potential predictive value. Important update was on the EVERA trial. The EVERA trial was a prospective randomized trial for patients with HR-positive, HER2-negative advanced breast cancer that compared giredestrant everolimus to standard of care plus everolimus. And the primary endpoint, if you remember, was, of course, invasive disease-free survival, median progression-free survival. The key secondary endpoint was overall survival. So PFS2 was evaluated in this study in both ESR1 mutant and not ESR1 mutant. And you can see that the benefit of the combination of giredestrant and everolimus was very similar in ESR1 mutant population, 19 versus 12 months, and the ESR1 not mutant population, 17 versus 12 months. When evaluating chemotherapy-free survival in the overall study, again, there is a delay in the use of chemotherapy in both ESR1 mutant and ESR1 not mutant. At interim overall survival analysis, there is a trend for overall survival benefit that is very similar in the mutant and non-mutant population. Of course, the most common anti-cancer therapies following the combination was chemotherapy, specifically capecitabine and paclitaxel. a few patients, 18% of them, received trastuzumab deruxtecan. So the conclusion of this PFS2 analysis is that subsequent therapies were generally balanced at the cross-treatment arms, and an improvement in PFS2 and chemotherapy-free survival that is consistent with the favorable overall survival data at interim overall survival analysis. Another important study in the metastatic setting was the Victoria-1. In this study, during ASCO, we presented the data in the PI3 kinase mutant population. So the primary endpoint was progression-free survival when comparing arm D to arm F, so specifically the combination of gedatolisib, palbo, and fulvestrant in PI3 kinase mutant versus gedatolisib plus fulvestrant. Here we have the randomization of study 313, 155 patients to geda, palbo, and fulvestrant, 52 patients to gedatolisib and fulvestrant, and 155 alpelisib and fulvestrant. Just to remind to you, of course, we have many patients with visceral disease as expected in this study. When assessing the primary endpoint, the triplet combination in PI3 kinase mutant, gedatolisib, palbo, and fulvestrant improved the median progression-free survival from 5.6 months in the alpelisib fulvestrant arm to 11.1 months in the triplet combination. Median progression-free survival benefit was distributed across all the subgroup independently of age, menopausal status, visceral disease or not, a previous line of treatment. In the secondary endpoint, that was progression-free survival by blind and independent review, we observed exactly the same results. Improvement in PI3 kinase mutant population from 5.6 months with alpelisib fulvestrant to 11.3 months with gedatolisib and fulvestrant and palbociclib. When moving to the PFS in the key subgroup, you have exactly the same benefit. In overall survival, of course, this is a preliminary analysis of the key secondary endpoint. At the data cutoff, there is a numerical improvement, but we need, of course, to have more data in this setting. When assessing response rate, the triplet combination doubled the response rate in this patient population. And the duration of response was, of course, longer in the triplet combination versus the dual combination. Regarding safety, the safety profile of this drug that is administered with the weekly intravenous administration was almost safe. There is no higher incidence of mucositis that is very well managed. Incidence of mucositis and stomatitis was around 16%, thanks also to the prophylaxis with the Swish mouthwash that, of course, can reduce dramatically this side effect. So in conclusion, the combined results of the Victoria-1 validated that gedatolisib, fulvestrant, and palbo significantly improve median progression-free survival when compared to alpelisib and fulvestrant in patients with PI3 kinase mutation. The rate of hyperglycemia was low, as was diarrhea, and also stomatitis was very well managed. And then we have the last trial, the Persevera. This trial was highly expected because this is one of the first trials assessing the role of oral SERD in endocrine-sensitive population. The Persevera trial was a prospective randomized trial including patients with HR-positive, HER2-negative disease with metastatic disease, no prior treatment with SERD, who had a disease recurrence after more than 12 months of completing neoadjuvant endocrine therapy, or also a disease recurrence within 12 months for patients receiving neoadjuvant tamoxifen or aromatase inhibitors. Patients have been randomized to giredestrant plus placebo plus palbociclib versus letrozole plus palbociclib. And the primary endpoint was investigator-assessed median progression-free survival. 992 patients have been randomized, 495 to giredestrant palbo, 497 to letrozole and palbo. Here we have the characteristics of the patients. The majority of them were ER positive, very few ER low, only 1.2%. The treatment-free interval less than 12 months was only 10% of the patients, more than 12, 68%. So the majority of the patients were endocrine sensitive. This is maybe a crucial, of course, inclusion criteria, maybe to explain the results. And the primary endpoint finally was the following. So giredestrant plus palbo demonstrated only a numeric improvement in investigator-assessed median progression-free survival versus letrozole plus palbociclib, despite the lack of statistical significance. So, in conclusion, the trial did not meet the primary endpoint. Median PFS was 28 months with palbo and letrozole versus 33 months with giredestrant and palbo, with an hazard ratio of 0.89. And when assessing investigators' PFS in key subgroup, we have exactly the same distribution, no significance in any subgroup. Maybe only the geographic region was the one. The secondary endpoint was overall survival. There is no difference in overall survival when comparing giredestrant palbo versus letrozole and palbo. Duration of response was almost similar, even if there is a numerically longer duration of response in the giredestrant palbo versus letrozole palbo, 38 months versus 30 months. Regarding safety, serious adverse events were very uncommon, and treatment discontinuation was very similar across the two arms, so safety was very good for both AI palbo and giredestrant palbo. So this is the first study that assessed the role of an oral SERD in metastatic disease, endocrine sensitive. The final results, unfortunately, did not meet the primary endpoint, even if there was a numerical improvement. This can be related maybe to the enrichment of endocrine sensitive population. Many of them were not with the ESR1 mutation. And is an important information on this one, since we have now the first data in the metastatic setting. Finally, I would like just to mention an updated analysis of the OASIS 4 study. This was a randomized double-blind study using elizanenant. This is an important drug and NKI inhibitor that can reduce vasomotor symptoms in patients who receive endocrine therapy. A quality of life analysis has been performed, clearly demonstrated still a benefit from this drug. You can see over here the data of quality of life in terms of reduction of the symptoms. And when using elizanenant, you have really much more control of the vasomotor symptoms respect to aromatase inhibitors. Also, in those patients with premenopausal disease, using a LHRH analog, and a very similar benefit in patients receiving ortamoxifen or aromatase inhibitor. So, in my opinion, this is an important drug, improving the quality of life. And we need, of course, to have access to drugs like this, because improvement in vasomotor, psychosocial, physical, and sexual aspects have been observed when using elizanenant versus, of course, the standard of care. So thank you very much indeed. I will be very happy to take any question.